Welcome, everyone. Thanks for joining us for our February CCTS Forum. I am absolutely thrilled that our topic tonight is low health literacy, the challenges in clinical and translational research. And we have a stellar lineup of speakers. Dr. Joy Dupree is with us. She's been engaged in health literacy research and activism for over 15 years and helped establish the Alliance of International Nurses for Improved Health Literacy, the Health Literacy Partnership of Alabama. She is a Robert Wood Johnson Executive Nurse Fellow and is also the Director of Community Engagement for the School of Nursing. She's going to provide an overview of low health literacy challenges and touch on the research she's done in this area. We're also going to hear from three other investigators researching low health literacy and patient outcomes, as well as touch on how to assess health literacy levels. Dr. C. Ann Gakumo from the UAB School of Nursing as well, Associate Professor, and Robert Wood Johnson Foundation Nurse Faculty Scholar. Dr. Daniel I. Chu, Assistant Professor, UAB Division of Gastrointestinal Surgery, and the 2018 James Pittman Scholar. And Dr. Samantha Baker, postdoc in the VA Quality Scholars Program, UAB Department of Surgery. And without further ado, I'm going to turn it over.
Okay. Good afternoon and happy Valentine's Day. It is such a pleasure for me to be here today to speak with all of you again. We had the opportunity to come last August or September, I can't remember, one of those months, and share a little bit about what I have done related to health literacy in our state and nation. And so it's always so exciting for me to be able to come to present, and I'm doubly excited today because I have colleagues here that have started conducting health literacy research, and just can't wait to hear their presentation. I believe I've got 30 minutes at the beginning, or do you want me to cut it off at 20?
20 for the overview and 10 for your research.
Okay, all right, well, it kind of all works together. So one thing I'll tell you is that there are a lot of embedded links in my presentation that I will not be pulling up today because of the time, but you will be able to access those later. So this will be sent to anyone that would like to have it, and I understand it'll be posted somewhere. So let's get started. Our objectives today are really to talk about the disparities of the population and what that means. How do we know? We're going to compare and contrast the economic impact of low health literacy in regions in the United States, discuss initiatives and metrics used in research with the focus on health literacy at UAB, and then also what's on the horizon in Alabama, and discuss maybe what's going on in the nation as well. So I have to give a lot of shout outs to Robert Wood Johnson because of my fellowship and the funding I received. I was able to use that for 3 years to really augment some of the work I was already doing, and particularly related to the Alabama Health Literacy Initiative that we were able to start under the governor's task force, and then later standing alone. So this is a definition of health literacy that is by the Health and Human Services. There's about 30 plus definitions for low health literacy or health literacy. And what troubles me about that is that nursing is not among one of the institutions that has officially defined that. And I've always thought that was just so wrong, because nursing spends so much time at the bedside with the patient and has so much opportunity to make a difference. But by and large, they were not part of the early research team that worked on this, but they're beginning to catch up. So I'm delighted to see that happening. But our colleagues in medicine have done an outstanding job really bringing this issue to the forefront. And the vast majority of research has been done by the medical community, and some by education groups as well as psychology. One thing I want to share with you from the WHO, and you'll see that that even precedes the definition from HHS, is that health literacy goes beyond the narrow concept of health education and individual behavior-oriented communication. It really addresses environmental, political, and social factors of determinants of health. Now, this was way before we had the term determinants of health. And I think it's such a visionary statement. And it's so telling because so many providers that I've spoken with that are in the nursing profession will say, that's patient education. We're already doing that. And so, we have to get them to lend their ear a little bit further sometimes to give them the information that this is much, much more than just patient education. And some of the patient education we're doing is not using best practices. So, in order to know we have a problem, we have to do an assessment. And these are two studies that were done in 1993, 92, 93, and then again 10 years later. And then 10 years after that, there was an international study. And it really each time showed us what we suspected. And that's that 12% of the population are proficient with health literacy. Well, that's us. That's folks that are in the healthcare industry or the highly educated that understand the lingo. Part of the challenge is the lingo. And so you think about what happens when somebody goes into the hospital and the anxiety level goes way up. Even healthcare providers often have very difficult time when they're faced with those situations. In Alabama, some of our findings are even more troubling because you can see by what's before you that 25% lack a high school degree and nearly 10% lack basic literacy. Well, what does that mean? That means they don't read or write or compute at a 5th grade reading level. They fall below that. So they are considered functionally illiterate, 10% of our population. You can't tell by the way they dress. You can't tell by the way they talk sometimes. They've become very good at coping with their deficiencies. And a lot of times a family member will be that person that interprets everything for them. And often you will see them together as a team and they don't ever want to leave each other's side. And there's telltale signs. I don't want to say that everybody that brings their spouse or partner with them is in that category, but be aware of that is going on quite a bit. This just gives you the makeup of the state and what it looks like as far as the counties, and it's pretty much what you would expect. Shelby County is really, the best county in the state in which to live if you want to be around a literate population, and then the others are sort of sprinkled in there. The Black Belt is very troubling, and we've done a lot of work to help the Black Belt, but some of that hasn't been sustained in the past, so we've got to look at how we can sustain some of the initiatives that we're putting into play. Disparities are somewhat what you might expect. Poor are disproportionately affected. Members of cultural and ethnic minorities, refugees, immigrants, non-native speakers of English, southern and western parts of the United States, those without a high school degree. But the largest demographic group of those that have difficulty with health literacy are the elderly, 65 years and older. And there's a lot of ideas of why that is. I'm not sure if a solid study's been done, but the further away they get from education, they came along at a generation that we didn't have 300 antibiotics to choose from. We didn't have, the complexity of our healthcare system now has gone into warp speed. And in the patient encounters, if I were to click on this, you would see one lady, and all of these were actual patients, and the IOM created these videos. So she says, I don't know what it is. I just take it because my doctor told me to. And so, when you get Dilantin, maybe mixed up with Dilaudid, or, or Dimetap, that's what is happening a lot of times with our elderly. And without a doubt, those are the population. That's the population we have got to be more cognizant of, because many times they present as very well-spoken, well-educated, and well-dressed. And that can be that is, don't judge a book by its cover, because you never know. So when you deal with those folks, you want to give them the information and then say, use your teach back method. Can you tell me what I've asked you to do, and tell me exactly what you're going to do when you go home? And that is a real quick assessment on your own that you can determine whether they need more help. Another anecdotal way to assess that I think is so cool is I've known physicians, particularly pediatric physicians, that will carry a empty bottle of amoxicillin with them because it's an easy computation on how many to take a day, 500, whatever. And so they will give that to the parent and they'll say, can you tell me how you would take this medication? And if they can't read that label and tell you, then you know you need to spend a little bit more time with them. Health outcomes in Alabama, we don't have a lot to be proud of, but we're working hard to change that. I do think in 17, I remember looking a couple of weeks ago, there's a little bit of improvement. I think now we're 47th out of, oh no, that'd be worse. Right there, we're 45. Right now, we're 47th in overall health outcomes. In plain language, health literacy contributes to misunderstanding, routine for patient discharge that we think they're understanding us, sometimes they don't. Mistakes, excess hospitalizations, and unnecessary deaths. Again, the demographics of the South are even more troubling. So I think a picture is worth 1,000 words. And if you look at that, you can see Mississippi and Louisiana are the only two states that fall below the disparity that Alabama falls. So thank goodness for Louisiana and Mississippi, but I'm sorry for them. And so you can see by the southern states, we really are the group that is at the greatest disadvantage. And some western states. And part of that is because of some immigrant populations as well. The economic impact, this is a little bit dated. It was in 2007. There's a very complicated economic formula that I'll be happy to share with you if you send me an email that I haven't figured out yet for Alabama, but I'm hoping to get with somebody at our business school to help me with that. Arkansas used that last year, and they determined that 1.3 to 3 billion each year in their state was wasted due to unnecessary health costs, and much of that was attributed to low health literacy. They got a $1.7 million grant in Arkansas to create a medical center university health literacy initiative. So that's real exciting. And to share, we're not pulling this out of the air. This has been around for about 15 years. The Institute of Medicine created a vision for a health literate America and really addressed every area they felt like was needed. So if you look at the first couple of ones, that may involve us as consumers or parents, but then you start looking and drilling down at the majority of things that are on this, and you see that, guess what? All of these are things that we have the ability to impact. So a great deal of it is our responsibility. When I've presented to different groups of healthcare providers, I've often heard, well, I can't do everything for them. It's not my responsibility. But we've got to do more. The patient needs to meet us halfway, but if the patient doesn't have the capacity to meet us halfway, then we need to get them with a navigator or whatever. And I know our world right now is so complex, we're trying to figure out how to implement the ACA and everything that goes with it. So we're in a perfect storm right now for health literacy initiatives to take hold. This page is from the CDC. I like to share this because if you go to this link, it gives you all kinds of information of what other states in the nation are doing. I hope Alabama will be black very soon, and I'll share with you what has to happen to get that. But this is their cover page for health literacy, and they've got tons and tons of links that will be helpful to you as a provider. There are training modules on that same website that there is a really great one that I would love to see our hospitals implement for all new hires that is basically health professionals, public health, and low health literacy, what you need to know if you're caring for any populations that have low health literacy. And this is what it looks like, health literacy for public health professionals. And it takes about an hour. It took about an hour for me. It might take an hour and a half for others. It gives you your score at the end, and you can take it over and over as many times as you want to get it right. It's free, and it also gives you CEs if you sign up for it, and that's free. So it's a no-brainer. We should be using this with every healthcare professional. Types of assessments, you know, what the health literacy research community really has come to the conclusion of, quit testing people, because we already know after 15 years of research, we know what the demographics are. They haven't changed in all those years. But what we have found is helpful is to implement a health literacy assessment tool in the clinic environment so that it can populate the EMR at the hospital, so that when the provider opens it, the first thing they see is this person's at risk for lack of understanding or low health literacy or whatever we decide to put on that. And there is a Florida hospital medical center that actually did that last year, and they tested it in the hospital. They tested it using the brief that I'll share with you in a minute. But I don't recommend that. I think it should be in the clinic environment because their anxiety level's the lowest at that point. You may get a very high rating if you do it in the hospital because they're going to be off the radar. And so nationwide, they use the NAL and the NALS. Then the international study came along. And then individual assessments are on my next slide, but how to assess patient education materials, it's difficult. And so before you have a consent form. One of my colleagues that works at the East Main Hospital System sent me an email last year, and she said, can you tell me who can analyze this for me and get it simpler? And I said, well, I'll do it for you. It won't take me long. So it doesn't take long to do it, but it has to be done on an individual basis. And so if you look at your handout, the first page is what she sent me. And then peel it back to the second page and look at just how much easier it is to see. The font matters, the white space matters, the number of syllables in each word matter. So I couldn't get that any lower than the 9th grade reading level. And I worked as long as I could to try to do that, but it just wasn't possible because telehealth has 3 syllables. And so when you have words like that in there, if you can take time to define those early on in your document, then you know you've got that covered. The other thing I recommend is that for people that revise their consent forms, to make sure that you put your original legally prepared consent with it so that you're covered. You know, because it makes attorneys real nervous when you start saying you're going to revise a consent form. But we have to consider that. The IOM is pushing for it, and the National Academies of Medicine now are pushing for it. And there's a whole body of research out there on just informed consent. How am I doing on time? Am I okay? Okay. Tell me when I've got 5 minutes left. And so how can you assess patient education materials? Some are on actually through Flesch Kincaid that's in your Word system, but then that doesn't tell you how to recreate them. So there is a link further in the presentation that I'll share with you. The Health Literacy Tool Shed has, I think, close to 300 or 400 assessments now. That's where you'll find the brief. And it was developed by a researcher with the last name Chu, and it was 3 questions. And then Jolie Hahn with the VA system came in and further refined it. It's been validated and tested and validated again. These questions are very non-threatening. And you can't get it off the tool shed because you have to actually send an email to the person that holds the ownership of that, but I have a copy of it. So anyone that would like to see that, I'm happy to send you a copy. And so the reason I like this one is because it's very non-threatening. We used to recommend the newest vital sign, but you had to actually calculate and do math to do that one. And we found it to be very intimidating with patients. And so the brief are 4 questions that are really like, do you ever have difficulty understanding medications? Do you ever have, so it's very, very open-ended questions. And so this is my baby. This is what I've worked on for the last couple of years, and Dr. Kokomo was a part of this as well. We have our leadership team in place now, who some of those names you may recognize. This is our website, and we're in discussions with a large insurance company in Alabama that we're hoping will fund our efforts. Research activities since May of so can I do in my research activities now? Okay. The behavioral risk factor surveillance system was implemented. Don Williamson implemented that before he left the State Department of Public Health. So we're at the end of our second cycle, so we're going to start analyzing that to see. And do all of y'all know what that is? It's a surveillance system that's sent to folks in Alabama that have been in the hospital, I believe. Isn't it? Y'all might have to help me with it. But anyway, we didn't have that data, and the CDC came out with the questions they wanted asked, and so we actually got a grant to implement that. The Alabama Hospital Association, I collaborated with them to do a research study. The geriatric scholars at UAB heart failure study is going on now. And then, so let me scoot real quick. This is the health literacy screening at UAB outpatient clinic workflow study that was done with the geriatric scholars. What we really did, we were trying to get buy-in from the nurses. We wanted the nurses to say, we can make this part of our workflow, because nurses are resistant to change. They don't want to add another assessment, but we got their buy-in for that. So now it's going to the next level, and it's actually going to be implemented. Connie White-Wibbs is going to implement it in the heart failure clinics. And so basically it showed us what we estimated, and we thought that clearly a third, have difficulty. This is what you have before you. This was our strategic plan, and all of this will be available for you to see later, but it gives you a lot of information about what we want to do for the Health Literacy Initiative in Alabama. And then this is a study that Leslie Pensa did, who is a MPH MD student that actually worked with Darlene Trappenstadt and another primary care physician in Bibb County to work on implementing a health literacy screening in those primary clinics, and she had some great outcomes. This is the Know Your Meds campaign. You're going to be hearing more about this. It is really supported by the Alabama Quality Assurance Foundation. And then the study in the hospitals, I just wanted to show you this real quick. Our methods, this was convenience. We had 9 hospitals that wanted us to analyze their patient education materials. Each one gave us about 10. So in all, we had 84 that we analyzed. And we also looked at the HCAHPS questions for patient satisfaction. So we took the hospitals, the patient education materials from those hospitals. We looked at the size of those hospitals, as well as the HCAHPS questions for satisfaction that are specifically for communication. And then we looked at the penalty for 30-day hospital readmissions. The smaller the hospital, the better the job they're doing. So these were our makeups, and you can't see before you, but the smaller hospitals are the ones that scored the best. This is what grade level they were written at. The American Medical Association and NIH say that everything should be 6th grade or less. And then if you looked at the readmission penalties, number 2 is void because it's a children's hospital. But this showed you the same hospitals and what their readmission penalties were. This was the most troubling to me because nurses are really not meeting even the national benchmark on what they need to do with communication. Physicians are. And then okay, so here's your hospital size and the satisfaction. The readmission penalties, again, the smaller the hospital, the fewer readmissions, and the better the HCAHPS data. This was the most troubling to me, and this is my last slide. About 10 to 15 patients reported when they were discharged, they didn't even get patient education or discharge instructions. Now, we know that's not true. We absolutely know that's not true. But we've gone in before and we've seen it left on the bed. Sometimes their anxiety level, again, is so high. But when you look at this further, those that did say they got it, only less than 50%, 49% said they even understood it. So we've got to do a better job. This is a study from Wisconsin. They're working on a drug labeling initiative that has been, California actually passed legislation with this, Red Toolkit, and then on and on. So my last thing I wanted to show you is simply put, and this is the document you can go to help you understand how to recreate information for your patients. This is actually a document that was used by Children's Hospital that one of my students recreated with the exact same information on it. And these are professional organizations.
We also have with us Dr. Robin Lanzi, Professor of Health Behavior and Director of the Student Engagement, School of Public Health, co-director also of the Behavioral and Community Sciences Core at the UAB Center for AIDS Research. There's going to be a panel discussion, a Q&A session, and she's going to moderate that for us. But now let's welcome Dr. Ann Gakumo.
Very good.
Thank you.
You're welcome.
Super excited to have you.
Thank you.
Brian, do I give her the mic?
Just bring that.
Can you hear me okay? Everybody can hear me okay? All right, so who here is good at math? A couple. I'm not going to ask you any questions to follow up, so people are always. I'm going to talk for a few minutes about health numeracy, right? So people are less familiar with the term health numeracy and what it can potentially mean for health outcomes. And of course, I've done quite a bit of work in health literacy, but I think that the work that I've done in numeracy can complement these talks quite well. And so basically, numeracy is, health numeracy is really the understanding of numbers within the context of health. And if you think about it, what does that mean, right? So if you're a patient, that could mean understanding vital signs, right? What does a blood pressure of 140/90 mean to a layperson, if anything, right? Understanding lab values, for those of us who work in HIV, like myself, what is a viral load of 1 million versus an undetectable viral load, right? Understanding even how to take your medications appropriately. So dosing. So if I'm a patient and I have a prescription from my provider to take 1 pill 3 times a day, how does that translate to what I actually do when I get home? Is that 1 pill every 8 hours? Is that 3 pills in the morning? Is that 2 in the morning and 1 in the afternoon? So all of these have to do with numeracy, also literacy, right? So they're very closely combined in terms of health. And so I would like to acknowledge my funders, some of the work that I'll be presenting today from the Robert Wood Johnson Foundation. In addition, Joy is one of my colleagues also in that regard. AHRQ, some of my K-12 work, I'll be presenting some of that, and also my work from the Dean Scholar Award. And I have like 10 minutes, and how can you present 3 studies in 10 minutes? You can't. It's difficult. I'd also like to acknowledge my research mentor who's currently working with me on my current randomized controlled trial. That's Dr. Mugavero. And also the 1917 clinic and staff. One of my employees is here, Dr. Eddie Jackson. So thank you and welcome. So just a little bit of background. I mentioned about what numeracy is. So there has been a correlation or, tons of literature out there within the HIV positive population showing a relationship between numeracy and higher viral loads. Some studies show poor CD4 counts and also some knowledge deficits that correlate with this and not adherence to medications. And as Dr. Dupree mentioned earlier, older adults are disproportionately affected, minorities, those who speak English as a second language. But it's interesting, there was a study done at Vanderbilt. Vanderbilt does quite a bit of health literacy work. And their team, Chandra Osborne, Russell Rothman, they did a study looking at racial differences in medication adherence for those living with HIV, and they found, as expected, that African Americans were less likely to adhere to their HIV meds than their white counterparts. However, when they factored health literacy into that statistical model, that difference dropped to non-significant. So really, health literacy can be a stronger predictor of outcomes than race. And I know Dr. Chu will probably be talking about some of the disparities work that he's done. Also, I'm going to be talking some about lab values. So really, for those of us who work in the field of HIV, viral load, CD4 count, that means everything, right? So if someone has an undetectable viral load, if they have a CD4 count that's high, that's good. So, what about what patients actually understand about these lab values? So we'll explore some of that. So I'm going to talk for a few minutes about the HALO study, which stands for Health Awareness and Literacy Outcomes. I'll talk mostly about the first aim, in which we looked at the relationship between health literacy and numeracy to people's lab values, that being CD4 count and viral load, and the patient's ability to actually recall what these values are. So we asked them, do you recall what your last viral load was or what your last CD4 count was in your last visit? We compared that with the EMR. And also medication adherence. We looked at cognition as well, but for the purposes of this talk, we'll focus on the first name. And so this was a cross-sectional descriptive design. We recruited all of our patients from the 1917 clinic, which is our HIV clinic here at UAB. In order to be in the study, you had to be living with HIV for at least a year, be over 19, currently on HIV meds, of course, and we excluded those with some specific cognitive impairments. We analyzed using SPSS, looked at Pearson's R, and also did some stepwise regressions. So these are the instruments that we used, and I think Dr. Dupree mentioned a couple of these, the newest vital sign, which is basically you're reading a label and a nutrition label, and you have to, it's administered by someone else, and you answer questions based on what you understand about that nutrition label. So it's like the nutrition label of a pint of ice cream, and you ask questions about that. And it not only measures literacy, but it also measures numeracy as well. So you kind of have to do a little bit of calculation as well. We use the Realm, which some of you may be familiar with, and that particular instrument is focused on word recognition. You know, do they recognize how to pronounce these words? So it doesn't really ask you, do you understand what these words mean, but can you pronounce them? So they measured different things, different levels or whatnot. We also measured numeracy, both objectively and subjectively. So some of the questions on the general numeracy tool ask them to assess, risk. So, again, that's numeracy. So if I start living a healthier lifestyle, this will decrease my chance of getting cardiovascular disease by 25%. Like, what does that mean to the lay individual? So it asks questions about risk, because that has to do with numeracy. But the subjective scale actually asks people's opinion on how good they think they are at using numerical values in everyday life, like balancing a checkbook and whatnot. We measured adherence and also HIV-specific health literacy by using the BECA, which is the Brief Estimate of Health Knowledge and Action. And I think, of all the tools that are out there, it's a decent tool, but just know that, if you're measuring health literacy, there are some disease-specific tools that are out there that are helpful to use. And this is one of them, because it actually asks about, lab values that are particular to HIV. And it has a few items on there that ask about adherence as well. Although the Cronbach's alpha wasn't that high, it was a little bit on the low side. So that was one of the limitations of the study. So we also developed some questions to determine if they understand what a CD4 count is. So we gave them their choice. So, based on CD4 count, what is a normal CD4 count? And they answered questions based on what they thought would be the correct answer. We asked the same thing about viral load as well. Some outcome variables, we did actually obtain their CD4 counts and viral loads from their EMRs. We checked their ability to recall. So I mentioned before, we checked their ability to recall their most recent CD4 count, and we checked the concordance with that. So if they were close or one off, so for example, if their CD4 count, the last one was between 200 and 499, and if they chose B, then we gave them partial credit for being a little closer had they, rather than if they were further apart than that. So we did give them 0 to 1 to 2 agreement based on the concordance of to the EMR. So I know you can't see this, I apologize. Most of the sample, 66% were male, 72% African American, 26% Caucasian. Majority had income of less than $10,000 a year, so 68%. Education level, however, at least 54% had at least some college. In terms of how they did on the health literacy measures, for the Realm, it turns out that 48% had poor literacy based on the Realm. For the newest vital sign, about 58% had either possibly limited literacy or low literacy based on the newest vital sign. And we also have a range for their lab values there as well that you can't see. CD4 count ranged from 38 to 1653 in viral load. And we'll talk about the correlations in a minute. So based on the realm, and please take this with a grain of salt, they're not strong correlations. They're a little weak, on the weak side, but they are correlations nonetheless. So those who had higher health literacy based on the realm had a higher CD4 count. They were also more readily able to recall what their last CD4 count was. And interestingly, they were more likely to keep their clinic appointments based on both of the health literacy tools. So based on the realm and the newest vital sign, health literacy was associated with keeping clinic appointments. So if you're someone living with HIV, you take your meds, go to your clinic appointments, you'll do really well and you'll live a very long time. Health numeracy, and this was the objective measure, was also correlated with keeping clinic appointments. And so for the part of the numeracy was we actually had them read like a medication bottle, and we asked them questions on how would you take this medicine. So that was pretty interesting. And we also had a slip that asked them, where am I on time? 2 minutes? Yeah, okay. Interestingly, we found that neither health literacy or numeracy was correlated with medication adherence. However, we didn't have the best medication adherence tool, I will say that. So I learned in the future, use more than one, right? Get a self-report one, get an objective one. So lesson learned. I won't talk in depth about this, but you can refer to it. This is a study that, well, this is not the right slide, but this is a study, Dr. Mugavero was also involved in this study where we actually recruited individuals after their clinic appointment. So they would come in and see their physician or their nurse practitioner, their provider. Then we would ask them questions right afterward to see, what do you take away from this clinic appointment? What do you understand about what a CD4 count or a viral load is? There was a lot of confusion there. Like even several thought that undetectable viral load was a bad thing, but that's actually a good thing. You want your viral load to be undetectable, but it has kind of that negative connotation, right? So there was lots of confusion with regard to the numbers, some confusion with regard to whether they should go up, down, which should go up, which should go down, the CD4 or the viral load, and whatnot. So that just lets us know, as people who, those health professionals who communicate with their patients, how to do so in a simpler way, because sometimes less detail is more. Medical jargon is almost never good, right? And on the bottom there, those are just, and I can pass these, I can give you access to these, but these are just some examples of numeracy. So moving ahead to kind of where we currently are in the mobile study. So I continue to work with HIV positive individuals. However, I wanted to look at the relationship between health literacy and adherence, but more so than that, to develop a health literacy based intervention to improve adherence. And so I work with older African Americans living with HIV, looking at ways to improve adherence to antihypertensive medications. And so we recruited a sample, focus groups, to see what they like to see in the intervention. One of the things that we have to be mindful of is that we can come up with the best program intervention since sliced bread, but if you don't have the buy-in, right, from the patients or the participants, it's not going to go very far. So we took a really concerted effort to see what they'd like to see in the intervention. We took time to develop a protocol to see what they like to see in the intervention, and we developed it and we're implementing it currently right now. And this is just the statistics from the focus groups, and they were around 59 years of age, similar to the study before this one, although this one was mostly female. So their health literacy based on the newest vital sign, most of them had some issues with health literacy, as might have been expected. And again, these are older individuals, because take into consideration that when you're older, especially when you have HIV, those CNS issues start coming in, and not only do you have issues with health literacy, but you also have cognitive deficits that come into play. So you're really aging at a quicker pace than someone who is of the general population. So just couple that and just know that, those are some really ripe areas for investigation. So some of the major themes that came from that was tailoring the health literacy program and the adherence program to their individual needs, communicating often, assessing understanding. They did prefer verbal communication over technology, no texting, that they weren't really fans of an intervention that included texting. But this is older adult population. Some of them, but for the most collective part, not so much. And monitoring adherence progress and providing them feedback in simple terms. And they really like the idea of having a peer. It is a peer-based intervention program that we're implementing. But here's just one very brief clip from one of the focus groups that I'd like for you all to hear. This was an individual who, hopefully this will play. This was an individual who was on blood pressure medication and didn't know he was on it. And so we asked him, well, how are you doing with taking your blood pressure medicine? And here. And that's more common than we think. I mean, my own grandmother has that issue. She takes her meds, but can she tell me what they're all for? No. So that's where that education piece comes in. And so here's the intervention. This is my last slide. What we're focused on now is it's peer-based, health literacy-based. And so individuals get contacted twice a week by peers who have that lived experience. And also we are assessing their health literacy needs on a weekly basis. They also get wise suggestions for goal setting. So not just the medication adherence piece, but also goals for nutrition, healthy living, and we record their progress. And so we have 2 peers. We split them in half, 1 male, 1 female. And we hypothesize that those who receive the health literacy-based intervention will have at least a 10% higher level of adherence to their blood pressure medications than those in the standard of care group. And we're monitoring medication by MIMS caps, by self-report, as well as by pill count. And so these are the other measures. There's probably almost a dozen measures here. The ones of note are the brief health literacy screen, the 3-item measure that was mentioned earlier, and also the STOFLA, the short test of functional health literacy in adult. And basically that, you read a passage and you fill in a blank. So it measures prose literacy. So you have to comprehend how the story goes in order to fill in the blank of a multiple choice item to make the story make sense. Does that make sense? Okay. And so it's a small study, and we're hoping to scale this up on a larger level. What we're doing right now is checking on the fidelity, the feasibility, the retention of the study to scale it up. And that's all I have. Thank you. Sorry.
Well, thanks. My name is Dan Chu. I'm one of the K-12 scholars, year 1 to 2. I'm a colorectal surgeon in the Department of Surgery, and I'll be talking more of a works in progress of our project, Understanding Disparities in Surgery for African Americans with IBD through health literacy. So IBD, or inflammatory bowel disease, is an entity that includes both Crohn's and ulcerative colitis. And for those not familiar with this disease, it's affecting more and more people in the US, over 3 million now. It's very costly, and it's also debilitating with sometimes fatal consequences. What's unusual about this disease is that many patients face major abdominal surgery in their lifetime. And these are not trivial operations. These are major operations where we have to resect bowel, reconstruct bowel. You're talking about stomas and all kinds of issues with the GI tract for life. So it's very serious. Now, just like there are health disparities in multiple diseases, more recently people have also started using the term surgical disparities. So it's the same concept. What this means is that after major surgeries, people are noticing now that certain populations, such as minority populations, have disproportionately worse outcomes in things like mortality, length of stay, readmissions, and even post-op complications. So this is this term, surgical disparities. So they exist and they're out there. And as surgeons, we tend to be behind the 8 ball. We're really slow in these type of things. But IBD is in particular one of the worst diseases. And what's interesting is that people used to think IBD primarily affected Caucasian Americans, but its incidence is rising in minority populations. And African Americans in particular with IBD have disproportionately worse outcomes. And we've studied this within our group, looking at metrics such as readmissions, stomas, and even hospitalizations. And it's basically far worse in this population for whatever reason. And we don't know why this happens, but the question we always like to ask is, well, what can we do about it? So how do we get to health literacy? Well, I'll tell a little bit of a story. 2015 and before, at UAB, patients undergoing major abdominal surgeries had basically length of stays that were longer than the expected length of stay, which is that black line there, based on their comorbidities and the type of surgery. But not only that, there was a big disparity. Patients who were African American stayed in the hospital almost 3 days longer than patients who are Caucasian. This is controlling for complications for really an uncomplicated surgical recovery. This is a phenomenon that is at UAB, but it's also been observed across the country. We've been able to publish this using national data sets. So this is one example of a disparity. Well, there's this Enhanced Recovery After Surgery, or ERAS. This is what that stands for. This is a standardized recovery program for surgical patients after major surgery. It was developed in Europe in the 2000s and was brought to the US probably about 7 years ago at big institutions like Mayo Clinic. So when we got here to UAB in 2015, we implemented ERAS essentially. So this is a hospital-wide program now for colorectal patients. And what you can see here is very obvious. Basically, all the patients do better than the expected length of stay. And not only that, but the disparity is eliminated for whatever reason. So this got us thinking, well, we can eliminate these disparities with ERAS, suggests to us that we weren't doing something before 2015. What's interesting is that ERAS emphasizes a lot on patient education. It, in a sense, almost forces you to talk to the patients, to every patient the same way, to give the same information, to set the expectations, how long you're going to be in hospital, you're going to be walking the night of surgery, you're going to be eating the night of surgery, all of these little things that, I don't think we were doing before. And so this got us as surgeons interested in this idea of literacy as we start using these terms. So the question really our group looks at is really what is the role of literacy in determining surgical outcomes and perhaps even disparities for patients with IBD is our focus for now. And we were really driven by this conceptual model, as you see here, which really just tells you that every patient who comes to your clinic comes with you at a set level of health literacy. That's kind of determined even before they met you in a clinic by these various factors. But what's important to note is that health literacy in other fields has a role in outcomes, but it doesn't mean that someone who comes to you with low health literacy is fated to have poor health outcomes. You can do things right in between, as shown here about the modifying factors at the system, provider, and even the patient level. So this project really, this is my K-12, essentially specific aim one is to assess health literacy. In the IBD population, are there variations in health literacy? This is something that hasn't been looked at before. And then to see if literacy, does this even matter? Is it related to outcomes? And then the last thing was qualitative, to actually look at these factors. Which of these factors is most important to patients and their caregivers? And so this is all kind of data that we've just done in the last 6 months. Specific aim one, we basically have looked at about 120 patients with IBD in our Kirkland clinic, where we have an IBD center. And you can see, we talked about some of these instruments. With the newest vital sign, basically patients who were African American were disproportionately had higher rates of limited health literacy. And using the REALM test, kind of the same observation. And what's interesting is that we used the STOFA, and we talked a little bit about, Dr. Gakumo talked a little bit about this. We actually didn't see differences with this particular instrument. And health literacy, as I think has been alluded to, is pretty complicated. There's multiple dimensions to it. And so that may be what we're seeing with these different instruments. But stratified another way, if you look at the NBS again, what we can see is that if we look a little bit closer, there's actually some differences too. So African Americans had lower scores on the NBS, but there was also a little bit of a difference between by gender and then also with age. As you get older, health literacy levels were lower. I think this has been suggested before too. The same phenomenon we've observed with the REALM test and then even with the STOFA test. Bottom line, this kind of preliminary data tells us that within the IBD population, low health literacy does exist. It appears to be more common within the African American population with IBD, and in particular is the older African American male with IBD, who may be at particularly high risk for low health literacy. So this may be a group to target for interventions first. As a side project in summer, we also looked at readability. So we talked a little bit about the Fleschkin case study. So we basically had a medical student go across all the different clinics at UAB, and look as the specialties you see there. And then, the NIH and AMA have a recommended reading level of 6th grade or below. CDC is about 8th grade. But you can see here, if we follow the NIH and AMA, we totally fail at this across all specialties. The best is plastic surgery. The worst is neurosurgery. And there's a variety of reasons for this. Put another way, if you look at the percentage of materials that is actually at the recommended reading level by the NIH and AMA, even my own specialty, colorectal, we totally fail. Okay, our material really is just unreadable. So our second aim really was to determine the association of health literacy levels with actual outcomes, looking at these particular metrics. And this is just basically a study where we look at readmissions, complications, and length of stay, and just add in health literacy levels as a covariate, essentially, to see if it kind of is associated with outcomes. So we haven't done this quite yet. This is in process right now. But what's interesting is about 3 months ago from Vanderbilt, they published a paper in JAMA Surgery, which actually linked health literacy with actual post-op outcomes. And what they saw is that length of stay, which I talked about this before, is actually much longer in patients with low health literacy by the BRIEF score. And this was significant. So this is really powerful because people haven't really shown this in the surgical world. But it seems to be linked to outcomes, and adds to the argument that maybe we should be also targeting health literacy within the surgical population. The last aim is a qualitative study looking at barriers at those 3 different levels. And I won't go into these details, but we do work with the Crohn's and Colitis Foundation, which is the only really foundation that's out there for IBD patients. Constructing interview guides, we'll be conducting focus groups, doing the qualitative analyses with our colleagues. Now, I will talk about some preliminary findings though in another study. This is a study not being done in just general global surgical patients, not just IBD. What's interesting in that qualitative study is that we've basically found some certain things. There are significant variations in knowledge about surgery recovery, major differences in the way patients obtain information. Patients really talk a lot about the poor quality of information that we give as surgeons, a lot of different expectations for surgery. And then when you look at, we ran focus groups of Caucasian groups and African American groups. Within the African American focus groups, there were more descriptions of folks having no expectations whatsoever about surgery, being provided inconsistent information, and even being misled about the surgical process, this issue of trust within the surgical journey. So what does it all mean? Well, future direction, there's a lot more to be done here. Ultimately, we wanted to develop a surgical care model that's what we would say is more health literate. The idea is maybe we can take existing pathways, such as this ERAS pathway that I talked about, and basically add health literate interventions to it, make it version 2.0. And then we can maybe adapt best practices that are out there for health literacy within the surgical continuum. And there are certain models out there. This is a great model that we've looked at. This is on health.gov, the health literate care model, really a synthesis of a lot of these healthcare models. It's an interactive website. You can click on each of these icons and tells you a little bit more about how to make your system or organization health literate. But things that you might have thought about here, improving readability. That's something that we're going to definitely start looking at within our surgical clinics. Using techniques such as teachback, right? As surgeons, we're terrible communicators. We tend to just spend 2 minutes with a patient, but maybe we should spend a little bit more time and actually ask the patients whether they understood what we just told them. And then really ultimately it's all about getting engaging conversations with patients and their caregivers. So I have a great crew that really kind of research staff that really helps us implement these studies, and also I have great mentors also, Dr. Kumo being one of them here at UAB that has helped make this possible. And feel free to email me with any questions down the road. Great.
Hi, everybody. My name is Samantha Baker. I'm a 3rd-year general surgery resident. I'm doing 2 years of research. And we just wrapped up enrollment in our study through the VA, and this is what I'm talking about today. So we're linking health literacy and surgical outcomes. So our study's patient-reported health literacy scores associated with readmissions following surgery. Background on the study, we designed the study to look at surgical readmissions, 30-day readmissions. And so that's what this study's powered for. And we had spent lots of time in our lab and our internal research group looking retrospectively at readmissions and trying to define models and predictive models of readmission. And it was really difficult to define, who's going to be readmitted, who's vulnerable for readmission, which ones are preventable, which ones are related to surgery, and all of these things. And several of these studies that we use retrospective data, big administrative data, and it gives a lot of insight, but it still left a lot of questions. And one of the things we were interested in is, we send people home and we don't have them in an environment where we can watch them. So what's going on there that causes them to come back? And maybe health literacy is that link. Maybe there's something going on at home that they don't understand or they weren't given information for, or they couldn't understand that information, so they decided to come back to us. So our hypothesis for the study were that patients with lower health literacy would be more likely to experience a 30-day readmission following surgery. This was an observational, prospectively enrolled multi-institutional study across 4 VA sites. Patients who underwent general, vascular, or thoracic surgery were enrolled. They had to stay in the hospital at least 48 hours and then be discharged alive. And prior to discharge, they underwent a measure of health literacy along with a couple of other measures. Patients were then followed for 30 days. If a patient was readmitted to one of the initial VA sites, they got an in-person interview to try and better understand why they were readmitted. Every patient underwent a 30-day chart abstraction to identify readmissions to other VA sites. When patients are readmitted through the VA, there's communication in the EMR about where they were readmitted and why, so we were able to chart abstract those. And then every patient got a 30-day follow-up phone call in order to identify readmissions that may have happened to some hospital outside of the VA system. And we did this to try and identify as many readmissions as possible. So we used the 3-question score by Dr. Chu. It's a 5-item Likert scale questions, and these are the questions. How often do you have someone help you read hospital material? How often do you have problems learning about a medical condition because of difficulty understanding written information? And then how confident are you filling out medical forms by yourself? It's scaled from never to always. So the first 2 questions, never indicates better health literacy, and then for the last question, it's flipped, and always would be better health literacy. For the purposes of this study, we made it 3 or less would be an indicated of adequate health literacy, but then greater than 4 would be possibly inadequate health literacy. So we enrolled 736 patients. Of those, 722 underwent the health literacy score, about 98%. The most represented surgical specialty was general surgery, followed by vascular and then thoracic. The 4 sites, 1 site made about 50% of our enrollment, followed split evenly by 2 sites. Our 4th site joined the study about a year in, so they were a little bit behind on enrollment. The demographics of our population is what you would expect of a VA population. They're older, male, mostly white. But how prevalent was low health literacy? Well, of the 722 patients who took the survey, 39.2% had a score of 0 or adequate health literacy, but 33.2% or 240 patients had a score of greater than 4, possibly inadequate health literacy. If we look at our population characteristics and stratify it by health literacy, so the first column has people who scored 3 or less or adequate health literacy, and the second column is patients who scored 4 or more. The races between the 2 groups is similar. There tends to be more African Americans in the inadequate category and more whites in the adequate category, but it's not statistically significant. Age is statistically significant, with 64 years being more likely to have adequate versus 66 or 67, to have possibly inadequate. We tend to have more females in our adequate health literacy group, but the N for females in the VA is typically pretty small. Interestingly enough, if you were married, you were more likely to have possibly inadequate health literacy, but if you were single, you were more likely to have adequate health literacy. And there on the bottom, Charleston Comorbidity Index is a measure of comorbidities. So our adequate health literacy group had a lower score, which indicated they had less comorbidities or were overall generally healthier. So for our whole study, looking at 30 days after discharge, 117 patients or 16.7% were readmitted and 20.5% presented back to the ED. So was this different based on health literacy? And it was. If we looked at unplanned readmissions at 30 days, 13.7% had adequate health literacy versus 22.5% had possibly inadequate health literacy. The similar trend was seen for ED visits. We weren't powered to look at that. I think if we had enough numbers, we would have seen something similar to this, but we saw statistically significant results with the unplanned readmissions. If we have a model for readmission, this is showing adequate health literacy as our reference. For possibly inadequate unadjusted, our odds ratio is 1.83. Once we adjust for the Charleston Comorbidity Index, the physical component score and mental component score, we have an odds ratio of 1.53. So that means patients with possibly inadequate health literacy at the time of discharge are 53% more likely to be readmitted as compared to patients with adequate health literacy. Again, if we look at the linearity between the two, for every 1 unit increase unadjusted, it's about a 9% chance of readmission, and that is statistically significant. Once we adjust, we do lose some of our statistical significance at a p-value of 0.08. But again, that shows for every 1 unit increase in your health literacy score, you have about a 6% chance of being readmitted. So with some limitations of our study, there are several tools out there used to look at health literacy. Not very many have been used in surgery, so this is the one we went with, and that's actually the one that Vanderbilt used too. So we'll be able to compare studies. There's some inconsistencies in cutoffs when you're trying to define that marginal zone. I think everyone can agree on adequate and inadequate, but it becomes a gray. Where do you draw the line for possibly inadequate versus inadequate? So we made ours like a dichotomous variable, but they were originally intended to be continuous variables, so that kind of muddies our results a little bit. And then again, this is a VA population, so it may not be generalizable to other populations. So in conclusion, low health literacy is prevalent among the VA surgery patients. It's associated with surgical readmissions, and future work is going to be focused on identifying these patients and developing interventions to educate and empower them prior to discharge. I'd like to thank our surgery team here and then across all 4 sites for all their help. And I'd be happy to take any questions on the panel.